So first we have with us Chuck Warwick. And Chuck is a board-certified advanced practice nurse and manager of advanced practice services for the Department of Neurosurgery and Neurocritical Care at Hackensack Meridian Health. And he's joined by Dr. Andrei Alexandrov this evening. He is a vascular neurologist and the chair of the Department of Neurology at Banner, which is at the University Medical Center, Phoenix. And I'm going to start by handing the mic over to Dr. Alexandrov to talk a little bit about the clinical challenges of dysphagia, how he first learned about phagenics, and finally a brief overview of the technology.
So welcome. Dysphagia is very common. That's number one. You have to look for it because it affects not only the quality of life, but also patients with stroke who develop dysphagia, they stay in the hospital longer. Quite often they require costly procedures such as a peg placement. It's an independent predictor of death. So aspiration is common, increased ICU, hospital lengths of stay, all that contributes to the problem. Okay, next slide. So about by now, a summer ago, my patient was living in 120 degrees summer heat, surviving a life-threatening cerebellar stroke with sequelae of ataxia and dysphagia, refusing PEG tube. She was a young mother, very proud. She didn't want her children to see her disabled. So she fought her way out after decompressive surgery, got back on her feet, was able to walk, take care of them, but she couldn't drink water. And so imagine in a heat, in a desert, she was living on Jello shots. That is not the way to survive. And so it's a matter of time when she would have gone with either diabetes or dying. So basically, I saw her after she was discharged already from the hospital, and I saw her miserable existence, and I basically called for help. I didn't know that this technology existed. In fact, I'm introducing it right now to my colleagues that it is the best kept secret in the United States. Because when I was trying to find a cure for the patient who refused PEG tube, through my connections, I was told, oh, this is the company that just opened an affiliate in America and received FDA approval. And I'm like, and why does anyone know about this? Well, because we didn't do a clinical trial in the United States, but the data from Europe was so overwhelming that this technology was made available to us in a proactive move by FDA. I was actually quite impressed. So we connected, and I basically connected my hospital administration with the company, and the rest was history. So let's show next slide. So it was approved already in Europe in 2012. And since then, Europeans continued to do studies, and the FDA based their decision on 5 different trials that were available from Europe. Approval in fall of 2022. And the first center started to implement that technology about 1.5 to 2 years ago. So guidelines are already supporting this in Europe. To date, over 5,000 patients were treated in Europe with no serious adverse events. So this is a very, very safe technology. Next slide. So, so it is based on a typical feeding tube. It's nothing different than a normal NJ tube that our nurses placing in patients in whom speech therapist said, oh, there is a swallowing problem. We need an NJ tube. The difference is the markers that you see on that tube. The markers will allow you easy positioning of an electrode, and These are two black markers, top left corner on the coil. You will see where they're going to be placed. So this tube not only can be used for feeding, but also deliver treatment, and it can stay in a patient as early and as long as a regular feeding tube. And then it is connected to a base station, and that's the source of electricity. It's very safe, it's isolated, it's like any other electrical device that we deploy next to the patient, and treatment is initiated. Next slide. So how does it work? So swallowing is a complex process that is not only involving a local mechanism right in the where pharynx meets esophagus, okay, but also it is linked. Advanced slide. It will show animation. So the signals need to go to cortex and either can be initiated from the cortex, or a local built-in mechanism will coordinate with the cortex bilaterally. That's the most important thing. Next slide. So it's a bilateral process. It's not like stroke on one side is going to destroy your ability to swallow. It can induce paresis, it can induce dysfunction of swallow, but the other side of the brain has the capacity to start helping. And next click. So it's a combination of stimulating locally and inducing basically neurostimulation and invoking neuroplasticity in the process of restoration of swallowing. Next slide. All right. So where does it placed? So you can see that NG tube is placed like normally with markers at the nose. And then you ask the patient to open their mouth. You can see green markers through the mouth, open mouth. You can see them. That means the black markers, that's where electrodes are. They placed exactly where the swallowing takes place. So you then determine the upper threshold. So first of all, you start inducing electrical pulses, and you ask the patient to show if they feel anything, and that determines the lowest threshold. And then you crank up the power essentially, and you you ask the patient, tell me when it's no longer tolerable, because those things, they kind of tickle, okay? They will induce swallowing, and so you want to know what's the minimum the patient feels and what's the maximum patient feels, and then you kind of go a third down in terms of intensity, and that's the comfort zone for stimulating of the swallowing. And then the treatment is administered for 10 minutes. So in 10 minutes, there are recurrent electrical stimuli that make the patient swallow anytime between 50 and 150 times. Try to count the number of swallowing tonight at your dinner. I bet you it will be less than 150. So here is your training in a very intense way. And you can repeat it daily. You can do it for 3 days, repeat swallowing assessment with speech therapy. A lot of patients make such an improvement that they say, I want to go all the way to make sure that I will leave nothing to improve. And so a lot of patients opt for all 6 days of treatment. So to sum up kind of how it works, imagine if you want to build muscles, right? You want to go to the gym, right? So what do you do in the gym? You take weights, right? And so what do you do with them? You stand with them in the gym. So now think for a moment what speech therapists are doing right now currently. They come in, they diagnose the problem with dysphagia, and then they tell the patient, get ice chips and put them in the mouth. And what? You're going to wait forever until ice dissolves? Or you're going to exercise with ice chips? How do you exercise with ice chips? It's like going to the gym and standing with weights. What you need to do is lift weights, right? And so this device takes you from ice chips to literally gym-like exercise of the swallowing apparatus. Okay, next time. And watch and wait, that's what we are doing right now. Maybe they will improve, but that will preclude PEG tube. Oh, no, not improving. Let's wait another day. So time is lost, length of stay is increasing, and at the end of the day, you're still ending up with a PEG tube, right? So what folks noticed in pivotal trials and also in our data is that the magnitude of the effect of this device is 30 to 40% absolute difference in terms of improved airway safety, improved swallowing, and returning to oral diet. These are very, very important things to prevent aspiration and to prevent PEG tube placement. From the patient perspective, you can't overstate how much impact is on quality of life. Next slide. And the other way. And here I will pass it on to my co-panelist and Emily.
Yes. So thank you very much, Dr. Alexandrov. Chuck, could you
Yes.
tell us about how you first learned about Phygenics and what the process was for you to bring it into your facility?
Sure. So we actually were reached out to by Phagenesis. One of our neurosurgeons, our chair of neurosurgery, knew one of the reps, and they discussed this new type of treatment to help with dysphagia, post-stroke. And at that point, as any chair of neurosurgery does, he finds somebody to delegate to. So I was delegated the task of kind of learning more about Phagenesis and Phagenics, as well as identifying who we really need to get on board to bring this into the facility. One of the people that we discussed was myself. I'm an administrator as well as a clinical provider. We spoke with our stroke neurologists, the director of the neuro ICU, who's here holding the box with me, and then our VP of operations for the hospital. When we identified those stakeholders, we had some meetings. Genesis did come out multiple times to kind of discuss the technology and the value proposition of bringing this technology into our facility. And they added a little icing to the cake by saying, hey, if you get this, you'll be the first in the Northeast. So any administrator in any hospital always wants to be the first in something. So that was kind of a drive to really kind of bring this in, get this going so that we can serve our patients in our population catchment area and try to treat a real problem. We decided that we were going to do a neuro ICU level of care in the beginning, just because it made sense as I ran the neuro ICU with the medical director. But as you'll see on subsequent slides, we did have to kind of pivot a little bit with that as well. Next slide.
Quick question for you, Chuck.
Yes.
What of the literature really caught your attention or caught the attention of the folks at the facility that made it compelling?
Sure. So we at first got a very extensive bibliography, or what I like to call a white sheet. I don't know if anybody else calls it that. But one of the studies was the FADER 2020 cohort study done in Europe that showed the effectiveness of PES treating dysphagia across diverse populations. And it demonstrated that it improved swallowing and reduced the dependency on feeding tubes with people with neurogenic dysphagia. We in the ICU were battling with just timing and length of stay, waiting for patients to get PEGs to begin with. And we felt that, well, instead of waiting to get PEGs quicker, why don't we found something that might actually get rid of them getting a PEG at all and be better for the patient, allowing them to swallow again.
All right. So what happened next?
So we decided to move forward. Again, we were driven by being the first in the Northeast to have a disruptive technology. We have a very concentrated area of health systems in New Jersey per se. So it's always nice to be able to offer a new disruptive treatment. We noted that it was also used at Banner, which is known for their stroke care with great clinical results. I actually saw a picture of Dr. Alexandrov's poster that he had there that showed their initial results. We noted that it was had proven results in Europe as well. We had no real other option to treat the cause of post-stroke dysphagia. As Dr. Alexandrov said, it would be swallowing exercises, external stimulation, and these things would only strengthen the muscle, but didn't really get to the actual root cause, which is what the Phagenics treatment does. We had a lot of quality improvement initiatives within our neurological ICU, including length of stay as well as stroke length of stay, and we wanted to see if we can decrease stroke readmissions. By doing this, we wanted to provide this new service to restore the function as eating and swallowing, because everybody deserves to eat. And if we had a possibility to give a person that ability, that was a huge quality outcome that we thought was worth bringing to the hospital and to our population. Next
So
slide.
now
Oh,
onto the most challenging part, Chuck.
Yes.
What did you do to get this, shepherd it through the facility process? I think this is a big challenge for a lot of folks as they're assessing a new technology like this and then trying to get it through the approvals process in their system. So who did you talk to? What did you say?
So, as Dr. Alexandrov said earlier, you need to identify a champion. It's critical. Luckily, he was able to pass it off to administration to be able to work on bringing it into his system. In my case, I was the administration that had to start basically driving this and getting this to the right people. And that included getting buy-in from the stroke neurologists. We do have a functioning stroke service in our hospital, and we had to get the buy-in of the neurologists to offer this and to order this, and to see that it would make sense to give this treatment to our patients. And then administration, it's dollar and cents, value analysis. What can this help us with? Quality is huge. But in the end, healthcare is a business, and we had to show that doing this did not really extend length of stay. We talk about giving 3 to 6 days of treatment, but what we started doing was to go along the lines of planning for a PEG, which in our institution took anywhere from 5 to 10 days. And we said, well, we're already waiting 5 days. That's 5 days of treatments that the patient's going to get, and they may not even need the PEG afterwards. The biggest thing was speech language pathology buy-in. I can't say enough that the critical part of my program with this was having the SLP team involved, identifying patients, doing the treatments, having the manpower. It was critical. Without them and their buy-in and the fact that they saw something that was disruptive and paradigm shifting, I don't think at Jersey Shore we would have been able to be where we are now. And then lastly was the neurointensivist, and that was really just based off of the fact that we were going to start this as a neuro ICU intervention in the beginning, until we realized at some point that most stroke patients actually don't make it to the ICU. They don't get TNK, they don't get a mechanical thrombectomy. So we started to go to the neurology floor and treat there, and we noted that the bulk of our patients were on the step down and neurology floor as opposed to the ICU. So we pivoted from that standpoint. The other part of the approval process was IT. Our IT is very risk adverse. They did not like the fact that there was a base station that held personal health information. So we had to develop a way to identify and de-identify the patients in the system themselves. So we had to work with IT, telling them there was no Wi-Fi connectivity, and that took a few months actually to get through from the IT perspective. We then developed a comprehensive education plan. Faye Genesis did come in and help educate all our SLP super users. They came multiple times to discuss nursing leadership and nursing floors, discussing and showing what these catheters look like. And it just took a little bit of time to kind of explain to people that this isn't anything new in the workflow. The only change to the workflow was really for the speech language pathologist giving the treatment. The biggest thing to hurdle was to tell people that this is a feeding tube, but it's a feeding tube with extra on it, and it can help these patients to not need a PEG. And that was a big deal, having the support from the company to help us educate from that standpoint. And then my administration allowed me to treat up to 10 patients to see what the results were and to see if we were going to continue and actually build this program out. So we did a few treatments, and it gave us some really great results afterwards. Next slide. So our initial 10 patients showed great clinical and health outcomes. We had at least the majority of them avoided PEG altogether. One of them had got a PEG. It was a large pontine medullary stroke. He received a PEG, but what was noted was we were worried he would need to be reintubated because he wasn't able to keep his secretions down. And even after the first treatment, we noticed better secretion management, and that actually, I think, avoided a readmission to the ICU as well as a reintubation. He then later, about 30, I think from 30 to 60 days, when we looked at his chart at the rehab center, he actually had his PEG removed and was on a functional diet. It did reduce our length of stay and our readmissions. Actually, and we'll talk about it later, but out of all of our patients treated, we only had 2 readmissions as opposed to the multiple that you would get with somebody with a PEG and aspiration pneumonia. There were a lot of clinicians that were kind of skeptical of the new technology. Obviously anything new, people look at it and say, well, this really something we need to have? It costs money, it's new, we have to learn. And the biggest thing was that there's no real change in workflow, as well as once we started seeing, even after the patient number one and patient number two, people not needing pegs and actually showing functional recovery, people's minds were blown. And that really was a turning point in the entire program. We were able to show these clinical outcomes and show the financial incentive to the institution. So we developed the program and we purchased the unit. And now all of the SLPs are trained. There was only a core group, but now all SLPs are trained. And we're actually even looking to get a second unit to expand our program further. Next slide. So the biggest thing as you know, I'll echo Dr. Alexandrov, is clinical champions are critical. If you don't have somebody pushing the drive to get this into your system, it's never going to get there. It's just going to sit on a desk or it's going to sit in an email box. I was a very squeaky wheel. I sent multiple emails. I called everybody I could. I texted everybody I could, and I didn't let things wait for too long. So, it was big on having a person driving it is critical. Nursing education and re-education is a large part of it. We had to really get around in terms of nursing thinking that it's a different type of feeding tube. It really is just a normal feeding tube, but we did educate about crushing medications and nutrition consults and things from that aspect. So we having that ability to work with nursing and concert and nursing leadership really helped us push this through, getting this into the hospital. You also have to identify who owns patient selection and troubleshooting from the provider side. The provider themselves, so at my institution, only providers such as physicians or advanced practice providers can place a guide wire feeding tube. Other places, nursing or SLPs can place it. So really, you need to identify who owns placement as well as who owns the patient selection. I defer to my SLP colleagues to find patients that have dysphagia or have bad secretion management, and they let me know when there's somebody that is a phagenics candidate, and then we work together and basically discuss it from that standpoint, whether we're going to go ahead with the treatment or not. The SLP department had manpower, which was very lucky, and many of them were very excited about this technology. As I said before, we did expand this to the neurological stroke floor because we found out that more patients actually were able to get the treatments there than in the ICU. And then it's ongoing educations and managing the expectations. Discussing with leadership and discussing with nursing that there are peg avoidance and lower lengths of stay. Those are byproducts of this technology. But the biggest thing is the life-changing thing it does to these patients who, earlier we would have to say, do these exercises and you may or may not get this back. But we can confidently say you have a very good chance to eat and swallow again. You have a very good chance that even though you had a stroke, we could get you to some functional recovery in terms of being able to provide yourself nutrition, which and I obviously haven't experienced it, but I know that from when I'm talking to my patients, when you experience a loss like that, it's critical. And knowing that there is an option there is huge. And we were able to provide that to our patients. Next slide.
Thank you. Thank you, Chuck, for being the squeaky wheel that you were and probably still are, because I know all those patients that the results you're going to review are thanking you for bringing this technology into the facility. So I'm going to pass it back to Dr. Alexandrov to talk about the approval process in his facility at Banner.
Yeah, so I used the surprise factor. I basically send an email on the 4th of July that would land on CEO's top as the first email in the morning, knowing that he will open it and see, oh my God, the patient is about to die. And so I was lucky to act both as a champion and the facilitator with administration. And I used my very top to basically call and saying, hey, y'all, that's Texas. Hey, y'all, the patient is about to die. We need cooperation here, and we need to bring this technology it's available. And so we initiated everything the right way. My squeaky wheel was Brenda Tulsi, so she's a nursing leader. And so she ran with it. And these are the actual dates in July when things were happening. And we were able to jump through hoops, meaning that we have our committees, our IT people, our whatever cybersecurity. So the catheter arrived by day 5. Okay, Biomed blessed the base station, and we were basically able to admit the patient and start treatment within 2 weeks of initiation of the process. So that's kind of was unheard of. But that's because her situation was really, really special and she was about to die. So 6 days later, I walked into her room and I said, "So, what's your favorite drink?" She said, "Coke." I didn't hold any judgment to that. I went to the station, got her a big bottle of cold Coke and gave it to her, and she gulped the whole thing without a problem. So we knew that she was cured that way. And then I saw her in follow-up. She lost weight. She looks fantastic. There is absolutely no deficit, and she's back at work. So this is exactly how you want to see people respond. So that was her kind of N of one, but similarly to what Chuck described, we got the first set of casters, and we were held by administration to saying, "Okay, we're going to be watching you. Let's see what you do with it." And we were super selective, obviously. We stayed on the label, by the way. The label is severe dysphagia after stroke. And so we stayed with that. And in the first 5 patients, we showed absolutely spectacular results. I mean, it was a combination of not only PEG avoidance, secretion control, but also patient satisfaction through the roof, to the point that a couple of them are now national advocates, and they recorded their testimonials in several interviews. For those of you who are on the stroke side, not necessarily neurocritical care side, think about Wallenberg syndrome. When they're alert, awake, they're upset that they're extremely disabled because their main problem is dysphagia. And these are kind of ideal patients who will jump on this opportunity and then will be your advocates. The other thing that Brenda shared with us is that we were under magnifying glass probably for the first 15, 20 cases because it's adding cost, but are we getting it back? And so I'm happy to report that NTAP payment, and Emily, you can speak to that. It's an important component for the hospitals that push the envelope with new technologies to recover some of the costs. So that has been very welcome, and we were actually getting payment. We continue to very kind of very detailed screening process. So speech language pathologists are our eyes and ears because they're going to be seeing those patients as part of their consults. So they're flagging them, and then in the first 50 patients, they would run it by the stroke team because these were the champions, and saying, "Do you agree that this dysphagia is neurogenic?" That's a broader term. That's how it's approved actually in Europe. But most of the cases are in hospital that are stroke driven, stroke neurocritical care driven, intubation driven. And so we will make decision together, and then they will do modified barium before and after, demonstrate, and I think one of my slides will speak to the outcomes. So next one. Yeah, it's this one. So I want you to look at third column, improve quality of life. So our speech language pathologists catch this scale. I like how it's called EAT 10. So they would survey the patient. What do they think at the end of the treatment? And some improvement was noticed by all patients. So it's like it's a really, really potent intervention. In terms of we had several scales, and in fact, if you're going to be implementing and assessing this, the recommendation is please use these scales because they're quantifiable. You can then show data to administration and saying, look, not only we avoided PEG, by the way, it's 2/3 on the right, and that's in the first like 12, 15 patients. Avoided intubation because we implemented it early and on a stroke team side, not necessarily waiting for prolonged intubation on neurocritical care side. And then we also looked at secretion and multiple scales that speech language pathologists use. All right, so this was very encouraging, and we continue to collect that data. Next.
Okay, I'll pass it back over to Chuck to talk about his results.
Thank you, Emily. So our results were kind of the same as Dr. Alexandrov. They were spectacular, as he said. We did a cohort, we did a matched cohort of 19 patients. And what we noticed is that there was a greater number of these patients, about 12 or 63%, that were discharged with an oral diet when they started NPO, and all the control patients ended up remaining NPO. There was a significant reduction in PEG placements. 42% of patients in the Phagenics group received a PEG. And then 100% of the NPO group received a PEG. So there was a significant reduction there. The mean hospital length of stay was 26 days versus 30 days, with Phagenics being at 26. Now, it wasn't statistically significant, but we did have only 19 patients. But that's still a 4-day length of stay that we were able to show to administration overall in stroke care. And then lastly was there was less stroke-related or PEG-related 30-day readmissions, with only 2 or 10% of the patients in the Phagenics group, as opposed to 36.8% in the control group. I do have some graphs to follow. Next slide. To kind of show, because I know administrators and others like to see the pictures. So this one's very telling. So these are patients. So the left side is the treatment side. These are all the patients that left that were able to eat. So they started not being told that, no, you cannot have anything to eat. You're going to need a feeding tube, and we're going to try this new treatment on. And 63% of them left the hospital with an oral diet, whereas 0% of the control group did not. Next slide. Another telling sign is here is look at the reduction in the PEG placement. More than half of less than half of the patients ended up with a PEG. And to be clear, this number was at discharge. Within 30 to 60 days, 2 more patients out of this group also had their PEGs removed and went to a functional diet, as opposed to the 100% that were discharged with a PEG and remained with a PEG, through the 30 to 60 days look through. Next slide. Hospital length of stay, obviously a reduction. Again, due to sample size, it wasn't statistically significant, but it was clinically significant, and more than enough for us to continue with the program in administration's eyes. Next slide. And then lastly is the readmissions. That's a huge stroke metric, with the guidelines and AHA and JACO. And we were able to show that only 10% had any stroke or PEG-related 30-day readmissions, which was huge compared to the 36.8 from the control group. And that did include patients that were multiple readmissions over the time. There was one patient that in the control group that was readmitted 4 times for PEG-related, but we did just count it as 1 readmission total. Next slide. So we did learn, again, clinical champions and SLP super users. You need these 2 people. If you don't have these 2 people, it's going to be very hard to get this program into your institution. Those 2 are huge. A multidisciplinary approach is huge as well. So, we have the providers, such as myself, as well as administration. Again, I take a different hat, such as myself, and then the physicians, the stroke team, SLP, nursing. They all are, and nutrition as well. They all work together to make sure these patients have the best care and have the best outcome. We developed a documentation toolkit that included a Epic ordering set, a head of bed sign, as well as documentation, as we use Epic documentation templates to help with capturing CPT codes and billing, but also for us to be able to follow through our data mining when we're looking for outcomes. We did need to start really learning more about the NTAP reimbursement. I will pass that off to Emily later on to discuss, but that is very important, especially when discussing about the reimbursement when you meet that DRG number for stroke reimbursement. And the biggest thing is that getting that reimbursement is important to help with the cost of the catheter as well. And then just targeted team education. You need to educate, re-educate. I would walk around in the beginning every time a patient was getting treatment, making sure the nurses knew what was going on, making sure SLP nutrition knew. Phagenesis, Anna Marie in my area would come and teach everyone multiple times. Anytime we had new people come on board, they were right there ready to help us teach, so that they don't just drop off the equipment and leave. You have a support system that stays with you forever. Next slide.
All right, this one is back to final thoughts from Dr. Alexandrov before we move on to questions.
Oh boy. So if you think about this technology, its effectiveness in your practice will be practically equivalent to what thrombectomy did to stroke. This is the same thing that it does to dysphagia. Every other patient will improve to the point that you will be saying like, wow. And then almost every patient will make small increment in improvement. This slide shows our second patient who is the star. He's a sous chef, celebrity chef in Arizona. He's very willing to speak about this. There are testimonies that you can see. It was life-changing event for him because he was working and couldn't work anymore. Imagine chef who cannot swallow, right? And I'll give you the opposite. So we had an unfortunate 25-year-old who had horrible thalamic stroke and was barely even waking up after that. So obviously he was trach and pegged. Trach came off because of the peg and inability to swallow. He was just laying there in bed like a corpse, waiting sniff placement. Obviously, young person, no resource. And my speech language pathologist said, why won't we engage him and give him this PES? And we were like, look, okay, you feel like let's try. So at the end of treatment, he was able to start swallow food, and he asked for steak, and he got a little piece of steak. And you should have seen how he perked up. He was still plegic. He was still modified Rankin score of 4. But he all of a sudden perked up, and he had really like his eyes came back, his energy came back. He wanted to be back with the family and interact, even though he was mute from his thalamic stroke. So that little push can make a huge difference in lives of these patients. So I'm gonna stop here, and I hope you guys started to put questions for chat for Carrie and or Emily, please facilitate discussion.
Absolutely. So yes, we would invite you to send through any questions for Dr. Alexandrov or Chuck about how they got this product into their facilities, their experiences thus far. I know some of the folks, I recognize a few names on here. Some people are just starting this process. Some people are nearing the end of this process, of the facility approvals process. So certainly drop something in. I think we have a Q&A option and a chat option. Both of you had referenced the NTAP payment, so I'll just quickly share what that acronym stands for and how people can learn more about that. That's the New Technology Add-on Payment. It is for Medicare fee-for-service. Some Medicare Advantage plans apparently do actually honor that as well, but primarily it's Medicare fee-for-service. And that's something I think it's been a learning experience for all of us, both on the Phagenesis side as well as the customer side, in terms of how that flows through a system. And I think the most important thing is to know that it's probably different in every single facility in terms of how it gets billed and coded. So we can't give you specific direction on how to make sure that your facility is coding for it, other than it's something to explore up front, early in the process, before you get the product in. And our team can help navigate that with each of your facilities, because it is so different from one to the next in terms of, again, how you code for it. But it does defray the cost of the system when you bring, or defray the cost of the catheters when you bring it in. So it's a great sort of add-on payment. And again, our team can help you facilitate that. So Chuck, you touched on this in terms of the support, and Dr. Alexandrov, I would love to hear how you have, worked with our team. I know specifically Alyssa has been supporting your site, and how our clinical specialists have been, what did you say, Chuck? Support for life? Support system that
support
stays
for
with you
life.
for life?
Yeah, we have a group text with our clinical, with Anna Marie, myself, and all our SLPs, and we just bounce ideas and thoughts about the the patients and everything. And it's great to know that at a moment's notice that if we have an issue, it's going to get handled, and it's been a great experience.
How about you, Dr. Alexandrov?
So my speech language pathologists were never looking happier than when they got that thing. Because imagine that all they do is just diagnose the problem, but then they offer very simple tools to deal with this. They don't have time to sit there and wait for patients to start using ice chips or whatever. So for them, it was really like 5 minutes to set it up, 10 minutes to treat. It fits into their busy schedule, and they can see the results. It's very important. It's almost like what we started to see when we started to give TPA. All of a sudden, these paralyzed patients are recovering. That's the same effect that you will be observing with that technology. And speech language pathologists are ideally positioned for that.
What sort of questions are you getting from your peers about this technology? I know that you've each heard from either other neurologists, administrators, advanced practice providers. I know that they've been coming your way because they've seen your the posts on social media or some of the news items. So what questions are coming your way, especially about getting this into the system, or maybe it's more general clinical questions?
It's expensive. Oh my God, this is a catheter. This is expensive. How we can justify? Well, think about this, that if you, like what Chuck showed, whether it's statistically significant or not, that's not how administration looks at it. 4 days reduced length of stay, calculate
Huge.
if it's 4 days of ICU, that pays plus a reduction of whatever eight PEG tube placements. That cumulatively, length of stay and reduction of procedures pays for itself. So you have better outcomes, shorter lengths of stay, and greater patient satisfaction. So right there, the cost of the individual catheter is can be easily offset by this. And then the second question is, we can't afford it. Well, if you dump it on speech language pathologists, they surely can't afford it because their budget is very little. So what we did, we offered it to endovascular, we offered it to neurosurgery, we offered it to ENT, GI, and everyone said thanks, but no thanks, because they are not really into dealing with dysphagia, although I was surprised that ENT and GI didn't jump on it in our place. So I said, okay, you're afraid of cost and you don't want to be responsible. I put it under neurosciences. we manage it jointly with neurosurgery, and we gave it to speech language pathologists at no cost to them, and that was the solution.
And that's what we did as well. We put it under our neuroscience budget, in terms of neurology and neurosurgery. And then we provide the tool to the SLP team to treat when they identify somebody. Another thing to discuss is, well, doesn't this mean that you're going to have 6 extra days in the hospital if you're giving 6 treatments? That was a big question when we first started. And, in the beginning, I didn't know how to answer it because I didn't see that it worked, like how it works. But then once we realized, and you can see by the data, we lost 4 days on our length of stay with most patients getting 6 full treatments. So at some point, we did come into the negative and was able to save on lengths of stay, even though they were there for 6 days getting treatments. And like I said, in terms of budgeting and the expense, that was a hard pill to swallow, no pun intended. But we were able to pass it through and show these outcomes and these clinical outcomes, and that alone was enough to say, okay, let's go ahead and keep this going.
Thank you so much, Dr. Alexandrov and Chuck. So far, there are some questions coming through the chat that I wanted to direct to you. Can you speak to what budget is this? You talked about financing. Can you speak to what budget does this come from in your institution?
Each institution will be different. So we
Yes.
managed to hit neurosciences because Chuck works for neurosurgery. I am very much working with neurosurgery on a daily basis. Administration kind of put us together in one bucket. I would suspect that whichever bucket neurocritical care comes into, that would be the next target. Because they basically deal with dysphagia a lot and secretions control. I think stroke doctors should be the champions of that because it is very frustrating to see patients with otherwise ready to go still dealing with dysphagia and secretions. So just to put even extra twist on what Chuck said, remember that your length of stay, that is usually around 5.5 days across all our stroke diagnosis, that includes TIAs and really quickly dying severe fatal strokes. But if you look at subset of patients with dysphagia, their length of stay is usually more like 8 to 12 days. So there is enough time to fit the 6 days of treatment and still enjoy reduction.
Yes, I agree.
Okay. Anything to add to that, Chuck?
No, he basically articulated it very well. Like I said, we found a problem with peg placements in general, taking sometimes 5, 6, even 8 days just to get a consultation and a peg placed. And a lot of times it's, who's going to place the peg, what service is going to do it. Oh, the patient's on dual antiplatelet therapy. We have to wait a minimum of 5 days. Things of that nature, depending on which service we were working with. So this kind of was able to just fit into that kind of timeline that we already had. And now these patients at day 6 don't even need a peg. So, 7, 8, 9, 10, 11, and 12 that we'd be waiting, they're already on their way to rehab or home. So it's that was the biggest, big impact from that standpoint.
Chuck, on that note, so when you showed your first outcomes, what resonated most with administration? Not with you, with whomever is you report to.
So when I discussed with administration, it was the length of stay reduction as well as the PEG avoidance. Because a few things I was able to kind of articulate with the PEG avoidance that one, you're saving, depending on who's doing it, you're saving procedure and OR time and cost from there. You're deferring cost of nutrition that the patient will need to have. Nutrition consultations and dietary consultations in the acute rehabs. We do have a lot of acute rehabs that we send patients to that are part of our system as well. So that saves the institution costs from that standpoint. And the biggest one was the 30-day readmissions. The fact that majority of the patients did not come back for any really stroke-related or PEG-related 30-day readmissions because that also takes away from the DRG payment if it's within the 30 days. So, stroke in general, isn't really a huge moneymaker for the hospital. But if you can prove to the hospital that, hey, now we're losing less money based off of these better outcomes, things like orthopedics and neurosurgery that actually make money, now they're moving that stuff into the green for the overall hospital budget. So when I phrased it like that, they were kind of very happy to hear some of those outcomes that we got.
That's awesome, Chuck. And and as we close up here, can you just speak to high level? Can you give just a general summary of like the patients, the types of patients you're treating, and the patients that you're selecting for this therapy?
Sure.
So I
Oh,
let Chuck go first.
yeah. So we mostly ischemic stroke. We've had the majority being ischemic stroke. There was 2 pontine medullary strokes that actually were the best recovering. We've had a couple of AVM ruptures, as well as 2 or 3 intraparenchymal hematomas. We did off-label use for a patient with a posterior tumor, who had dysphagia post-resection that we tried it on, and she's now eating a diet. And we did it to her. The real reason why we decided to go off-label was she wasn't going to be able to take her chemotherapy because you couldn't crush it into a peg. So this was kind of a last-ditch effort and a discussion with oncology, to say, hey, if we can get her to swallow, she can take her chemotherapy, and that was enough to make us say, you know what, let's decide to use this off-label and do it, and it worked for her as well.
Wow, that's really powerful. Thanks, Chuck. Dr. Alexandrov, you've been using our Phagenics therapy for a while now. Can you speak to the types of patients you're treating and what your plans are in the future use?
So thank you. Yes, the speech language pathologists, as I said, are driving this implementation right now and use. And so every time they come across the patient who fails modified barium swallowing or NJ tube was placed on clinical grounds, they think about, is this patient good for that particular technology? And the patients whom you probably don't want to do it on are the patients who quickly turn around. They're progressing, they're gonna come off. That's great. And then you probably don't want to procrastinate too long on a patient who is, they're not gonna get progress. And that's where we talk to and saying, are we going to drive to a meaningful outcome if we're going to do this procedure early, or the outlook is so bad that no matter what, there is no quality of life. They would never regain consciousness. They would never participate and stuff like this. So you quickly identify these 2 extremes, and then in the middle are probably your best candidates that you should probably start the sooner the better. And what we found is as other doctors hear about us, then they start calling us on all sorts of tumors, peripheral nerves, neurogenic dysphagia. We're already getting requests or referrals from outside the stroke box, so to speak.
Yeah, we started getting those as well with some of our DBS patients, as well as some of our high frequency ultrasound patients with thalamotomies. We get those as well.
There are a few more questions that have also come in the chat, but I know we're at the top of the hour. Emily, should we? I want
I
to be
think we should do a
respectful.
lightning round for these 2, for the MRI compatibility. Carrie, do you want to take that one actually?
Yeah. So, can you speak to your to the MRI compatibility? We know that that is a theoretical risk and a current contraindication for Phagenics therapy. We're exploring that warning in the future. But how is that? Has that caused any disruption in your treatment plan at
Right.
your
Well,
institution?
box is not MRI compatible. We know that. So,
The
so don't
catheter.
bring the box there.
Yeah.
The bigger question is not MRI, because I think by the time you are committed to treatment, it will be MRIs will be in the past, in the rear mirror. But what is more complex decision is loop recorder.
Mhm.
And we just had 2 patients in whom loop recorder was in place or placed, and we stimulated and we interrogated loop recorder, and there was no interference whatsoever.
Same here. We had a patient with a loop recorder, and just out of due diligence, we did ask cardiology to come and just comment on any contraindications from their professional opinion, and they said, have at it. And we treated them, and these were one of the patients that ended up leaving with a functional diet. I could answer the fees question too if you want to move to that
Yeah,
one.
go ahead. Yeah.
So in terms of fees, that's actually predominantly what our SLPs do. It's very rare, unless a fees can't be done for whatever reason, it's very rare that we will get a modified barium prior to the patient starting Phagenics. So all of our SLPs are trained with fees to be able to do it pre and post. We do remove the catheter post because it affects the swallowing quality from what the SLPs do tell me. It affects the overall swallowing quality when they're doing the follow-up fees or modified barium. So once they get the 6 treatments, we do remove the Doboff catheter to do the fees to give them the best chance to grade them as well as they can get.
Okay.
Actually, we have 2 minutes left since we started it a couple minutes late. So there's one more question.
Yeah, there is one more question. This one's for Chuck regarding readmissions. Do you know what percentage of stroke patient readmissions were due to PEG, or are there other reasons?
So I think a lot of readmissions that are, kind of in the bucket that we're talking to is due to aspiration pneumonia related to PEG, due to PEG dislodgement, clogged PEG, where they have to reinsert it. Off the top of my head, I'm not so sure the actual percentage of readmissions of all of our stroke patients, but I do think predominantly patients that get readmitted that have a PEG, it's due for those types of reasons. Now, other patients can come to the hospital that they didn't have a PEG because they had either silent aspiration or something where it just was not readily apparent upon discharge, and then they end up coming back with an aspiration pneumonia or another stroke. Per se, when it's not somebody that's left with a PEG to rehab. What about you, Dr. Alexandrov? What do you think?
Well, the worst I've seen is when people forget abdominal binders and PEG is hanging unprotected, and then the patient removes it themselves. I mean, it's just unfortunate. It's sloppy care. And also reinsertion, reinfection, clogging, exactly the same themes.
Yeah.
Last question, I think, as we wrap up this evening, if you had one piece of advice for someone, for a team starting this process, what would it be?
What are you waiting for?
Yes. Yes, this like Dr. Alexander said, this is as important as the thrombectomy or TNK was to stroke care. And reading the literature and seeing the results, it's amazing and exciting to be able to be part of this technology and this paradigm shift in care for these patients.
Go exercise.
Yes.
Thanks so much to both of you for participating in this webinar, sharing your experience with Phagenics, both from a clinical standpoint as well as a facility administration and approvals process standpoint. So, and thanks to all who joined us for the hour, and looking forward to hearing from the folks who attended about how their onboarding for Phagenics goes.
Thank you very much.
All right, thank you.
Thank you.